My name is Jim Reiser, and I specialize in the treatment of chronic pain and chemical dependency. Historically, we have been dealing with probably the worst opiate epidemic in the history of the United States of America. We've really overshot the mark on opiate management. However, we still have the challenges to help people when they have acute and chronic non-cancer pain, and we want to help those people. We took 3 different vignettes today to explain how we can help folks without over-medicating them, without enabling them if they do have a concurrent addictive disease, and also to help us understand that each patient is a unique individual and not a cookie cutter. So the good news is that there are ways to help people that are challenging with chronic non-cancer pain and chemical dependency. The bad news is it does take time. But we as clinicians owe our patients the best care that we can possibly give. But unfortunately, in the past 15 to 20 years of pain management, we've caused a lot more harm than good. These vignettes demonstrate ways to do more good than harm.
Hi Megan, I'm Dr. Jones and I'm back again. I wanted to let you know that all your tests came back and thankfully everything is normal again.
Normal? I have just, it can't be normal. Okay, what was normal?
The tests that we did, so we did a lot of tests on you today, maybe many of them that have been done before, but I'm glad that they came back normal. It shows us that we don't need to do any surgery or anything that's really urgent for you. We just need to somehow control your pain better.
Yeah, so last time when I had this same pain, they did that CT scan and they said it was normal, and then I came back, I don't know, I had worse pain, and I came back a day or 2 later and I had diverticulitis, and then I was in the hospital for a week, and they thought my colon might rupture or I would have an abscess, and so my stomach really hurts and I've been having diarrhea, and so even if it looks normal, I don't know about that.
Yeah, I understand your concerns, and I looked back at that record, and they did admit you and do some more tests, and they weren't really sure about your diagnosis. They thought maybe diverticulitis, and they thought some other things, but in the end, everything turned out to be okay then too, and they didn't need to do surgery or do any interventions on you then. It was really more about controlling your pain.
So I gotta have something for this pain.
Yeah. Well, I'll get you something. I want you to be comfortable, but I also want to talk about your pain a little bit, because I reviewed your records and I can see that you've had a lot of pain.
I have. Nothing can control it. Yeah. They get something like sometimes. One time I had that fentanyl, and I felt better. That was the only time I've been pain-free, where my pain was really maybe a 0. But like right now, it's like an 8 or so, and then sometimes I don't know if I have to cough, it'll be a 10 or even an 11. And so whatever you're giving me is doing nothing.
Yeah. Well, I want to get you some more pain medicine now, and I'll do that. But again, before I give you too much pain medicine, I just wanted to talk about the pain that you've been having for all these years, and about how hard it seems like from reviewing your charts. It looks like it's been really hard to control for the most part.
Yeah. When I get with it, it's not just stomach pain, but then sometimes I get these horrible headaches, and they say they're not migraines, and the migraine medicine doesn't work, and then I get this pain that shoots down my legs, and they tried something else for this. So I need someone who can help with all of this pain.
Yeah,
it's a real medical problem.
I agree that the pain is real, and it's really causing a big change in your life. And as far as I can tell, the medicines that have been used, they give you medicines and they work for a little while, and then it seems like they're not working anymore.
Or they take them away. We get something that just finally works, and then,
Well, as far as I can tell, that all this medicine actually has kind of increased your pain over time. That over time, sometimes these pain medicines, they make yourself and your body more sensitive to the pain. And that's the way that pain medicine works. We didn't realize this a few years ago, but now we're understanding pain more and how the actual medicine can make it worse. So I really want to get you into a program where we can address your pain much more effectively, where we're not just using more and more stronger and stronger drugs that are causing other side effects and actually increasing your pain over time.
So I would think about that, but I feel like before I need to have my pain controlled to be able to want to be part of a program to help with my pain.
I agree.
Because I can't function. I can't work. I can't.
Right.
do the dishes. I can't get up and do anything.
Yes.
I can't be my normal self. I don't have a normal life.
Yes, I understand, and I think that when people get into the type of pain that you've had, that is very common, and that's why I want to refer you to people who manage the chronic pain in a more modern and effective way than you've had in the past. And I think that you'll have a lot of benefit from this approach.
So what will they do to help? I mean, will they give me more medicine, or what will they do to help with my pain?
They will give you medicine, especially at first, but they're also going to look at other ways to treat your pain that are in addition to the medicines, and eventually will increase your need for medicines.
So will they figure out why I am in so much pain?
They will definitely want to have your medical parts addressed to make sure that there's nothing that's causing the pain that can just be stopped. But it's from looking at your records, most of that's already been done. So they'll want you to have a doctor who's also looking around the medical part of it to make sure that your care is good for the medical needs.
So here's my concern. I'm worried that there's just something going on inside that no one's ever figured out. Because why would I keep having all this pain with all these tests being normal? There's something that's not being looked at or found? Or...
No, I understand. And they'll look for the medical causes, but they'll also consider that the pain medicine that you've been receiving already is contributing to the amount of pain that you're having, and they'll address that so that you're having less pain. So that one way to take care of this pain is to decrease the therapy that's going to be actually making your pain worse right now. So let me say that a little differently. I know it's a little bit maybe not clear there, but what we really want to do is address parts of your pain that we know we can address, and that will, it seems like it might be unusual and it's not the way you've had treatment in the past, but I think we covered that what's been done in the past hasn't been working great for you.
It's not working.
And so this is a different way in which the pain medicine may be actually increasing your pain. So what we would really like to do is look at ways where we can use other approaches to the pain, but also decrease the medication part, because the medication may be making things worse.
Okay.
I think in your case, clearly it is making things worse.
So how long before I don't have pain? When will that?
Boy, that's a great question, and I can't promise you that you're going to be pain-free. A lot of patients with chronic pain, they don't get to the point where they have no pain. What they do is they learn to live with their pain in a way that is productive, and they're able to do the things that they want in their life. And that functionality is much more important than just getting the medicines that they feel may make them feel okay for a short period of time, but in the long run it's not been helping them.
So how do you learn? I mean, that sounds miserable to always have pain.
You know, it does to you, but I think that when you reflect back, you've had some pretty miserable times the past few years. So what I really want you to do is keep an open mind to the specialized care that I'm going to refer you to, that we'll have a different approach and will really increase and improve your life. That's what we're going to do. Does that sound good?
Yeah, so for now, what are we going to do?
I'll give you a little bit of pain medicine now,
Okay.
because I do want you to be comfortable right now. But I want to let you know that when I give you this pain medicine, part of the deal is that I want you to follow up the way I'm referring you, because it's a better treatment for your pain.
Okay.
And if you'll follow up the way that we're recommending, then I think that you'll get better care and you'll have a better life. And if you don't follow up, that you just come back to the emergency department, over the course of time, we're not going to be able to give you pain medicine, because we know that's not as good as a treatment. We know it's not as good, and so we need to give you a better treatment, and that's what I'm referring to you to now.
So I just have one more question. When I leave the ER today, because even if my pain is a little bit better, if it's not gone, can I have some pills just to get me through until I start?
You know, let me look through your records, and I may talk to your doctor a little bit, and we'll decide about that. So I don't want, what I want to do is make sure that you're comfortable for right now. And I don't want to just cut off your pain medicine right this minute, but I do want to refer you, and I want to talk to your doctor so that we make sure that we're on the same page with your treatment.
Okay.
Okay?
That pain medicine would be great.
Okay, let me go get it for you now.
Thank you, Doctor.
Thank you.
If you notice, Dr. Jones is actually engaged with this patient. He knows that this patient likely has some chemical coping issues, but he is validating this patient's pain. He is making sure that he listens to what the patient has to say, before providing additional information. I think as professionals, one of the things we want to do is step right in and stop the patient from continuing to behave in a way that may be feeding addictive disease. And the best way to approach that, frankly, is to get on the other side of it by allowing that patient to say what that patient needs to say. Once that patient has finished saying what they feel they need to say and felt listened to, that's when the clinician can step in. And as you see Dr. Jones stepping in a way that is providing clear boundaries for that patient, providing treatment for that patient, and most of all, caring for that patient. So in the acute pain setting, where Dr. Jones is working with this patient who's had acute pain but chronic onsets of this acute pain, it's clear that the medication management is not the way to go. There likely could be an iatrogenic addictive disease, and it's important to address that. A lot of times people are afraid to address addiction because of what the reaction might be. And sometimes the patient's reaction isn't a very pleasant one. But who's diagnosed terminal cancer on somebody and had a party after it? Diagnosing addiction and chronic pain and telling the patient some of the truths that some of this pain is not going to be manageable, some of the pain is not going to be managed by the pain medications in the acute setting, and that sometimes when we have a chronic illness, there's going to be levels of recovery, because denial and resistance to treatment are the two hallmarks for every new chronic diagnosis. We all know this. So it's not going to be any different when we're dealing with addiction and chronic pain. Explaining iatrogenic addiction and also removing fault from all parties has been a real help in working with a patient who's been chemically coping and may have gotten themselves addicted over time. Hey, my name is Jim Reiser, and I work in chronic pain and chemical dependency.
Nice to meet you, Jim.
Yeah, so you know why I'm here?
No, I don't.
Okay. Well, I went over your chart. Your doctor had said that he was concerned that you've had a lot of medication for the pain that you've had, and you had a long term with chronic non-cancer pain, but he thinks that maybe you've gotten a little bit trouble with the medicine itself.
Well, trouble in what sense?
Well, he thinks maybe you might be taking a little bit too much, but you tell me what you think.
Well, I think I'm taking just enough because it seems to be controlling my pain pretty well.
Okay. Let me ask you this, because I don't want to start off on the wrong foot. A lot of times people kind of get nervous when we're working with chronic pain and with chronic pain medication management. But I went over a report that you had, and we're able to kind of look through the pharmacy directory. And when somebody's getting prescriptions from more than one physician, which you have, that kind of alerts us to some possibilities that we might be hurting you as medical providers. And that's something that I really take responsibility for, is to make sure that we don't hurt you. So tell me a little bit, have you not had good pain management from the physicians that you've gone to see? Is that why you've gone to see several different physicians over the last several months?
Yeah, I've gotten it from the one and they give me some for a while, but then there's just not enough, so I just have to get it from somewhere else.
Okay. Have you gotten anything off the street at all?
Not off the street, but I have some friends who
Some friends?
from procedures or something, they have leftovers.
Okay. Well, have you ever felt like maybe you had a problem at all, or?
I don't think so.
Okay. I noticed your urine was positive for opiates, which we expected. Okay. And we always do a urine screen anytime that somebody comes in the hospital. But I also noticed you have marijuana in there. Tell me a little bit about that.
Sometimes the pain medicine just doesn't do enough. It helps to just ease it back a little bit.
Okay. So what I'm hearing you say is that you're using medications really to treat pain.
Mm-hmm.
Have you ever been able to get off of these meds at all and try to manage your pain that way?
The few times I've kind of ran out of pills, it comes back so bad, I don't want to not have those.
Okay. Has anybody ever told you about withdrawal?
I mean, I've heard of it.
Okay. Let me help you out with just a little bit. One of the things that we've learned over the past several years is, science is kind of catching up with kind of what we've known for a long time, in that sometimes the pain medications themselves can cause more pain, especially when you're withdrawing. So you've always got physical pain. That's just kind of part of your nature, and I get that. But the other thing is that the medicines themselves, as you begin to come off of those medications, you'll have what's a withdrawal syndrome. You'll kind of feel sweaty. You ever notice you feel like you got the flu a little bit? And it kind of goes away when you add a medication to it. And then have you noticed that your pain is actually worse coming off of them?
Yeah, I guess, yeah.
Okay. So this is what we call iatrogenic addiction. This is not a mean thing. It's not a judgment thing. A lot of times people hear the word addict and they get freaked out, and I don't want you to do that, because I'm not here for that. My job is to help you kind of get better as quickly and as efficiently as possible. And iatrogenic addiction means that we got addicted to pain medications based on being prescribed them. It's not your fault. It's not the physician's fault. It's just something that happens. You know, a lot of times you'll see people get other chronic diseases like diabetes, and if they eat too much sugar, how did that happen? It doesn't really matter to me how it happened, it matters that it happened. And if it did happen, that's something that we can treat. Have you ever heard of addiction before?
Yeah.
Do you have it in your family at all?
My dad used to drink a little bit. I don't know if he was an addict though.
Okay, did you have, what would make you think a little bit or not an addict?
I mean, I'd have seen him have some few beers every night, but I didn't know how much he was actually drinking.
Okay, any sisters or brothers that have any issues with drugs or alcohol?
No.
Okay, how about any aunts or uncles?
Not that I know of.
Okay, good. You know, again, that's also a family base, so you know you may be at less risk, but if we continue to expose you to these medications like this, we increase your risk. And so I'd like to give a chance to maybe start thinking about getting you off of these medications. It'll reduce your hospitalizations. It'll make things a lot healthier and happier for you if that's something you'd be interested in trying.
So you wouldn't give me any pain medicines?
Well, right now while you're here, we want to make sure that everything's okay, and you would have some medications, but we wouldn't want to just stop those abruptly because, again, that takes you to that withdrawal. It's kind of scary.
Right.
And have you gone through withdrawal before? How many times have you gone through it?
I mean, I've ran out of pain medicines maybe once every couple months.
Okay, so you've been pretty consistent with that. It's pretty miserable to feel that withdrawal. And so we'll do everything we can to help make you comfortable for that. And, you know, in the acute pain situation, because of some of the chemical coping that you've had, we will use what's called a long-acting medication instead of the short-acting. Remember, we were giving you that medicine in the IV when you had your IV in. And then we switched that over to the meds that you take by mouth. But even those can be short-acting, and those can trigger some other issues other than pain management. And kind of what I'm hearing you say is that your pain hasn't been well controlled by these meds anyways.
Well, it seems to work, but when I don't have them, it's when it causes the problem, yeah.
And then, so my hope is that you'll give it a chance to get off of these medications and do some lifestyle changes to see if we can't help you feel a little bit better. Because I know, you know, initially, I understand people hear the word addict and they think, oh wow, now they think that I'm something that I'm not.
Right.
And the way I look at it is I don't really care one way or the other, because that is an illness like any other illness that can be treated, and it's treated quite well. And so the good news is that if we can help get your pain under a little bit better management for you, get you off some of these medications, do some lifestyle work, and I'm not going to lie to you, this is not easy work. This is hard work. Do you have days available, like several weeks worth of days?
I guess I could make time.
Okay, because that's the way it's going to be. Are you willing to work for it? That's the other thing that's a tough question to answer sometimes.
I don't know if I just want to give up those pain medicines though.
That I understand. So what my hope is that you'll give me a week of your time. If you'd be willing to at least try that, and we'll work together. And I'll also introduce you to some other people that have long-term chronic pain that have kind of been where you are and can kind of help you get through on the other side of it. It's a pretty cool program.
Okay.
Do you think you might be interested?
Sure, I can give it a shot, yes.
Okay. While you're here in the hospital, I'm not concerned about getting you off of anything. Okay, we're going to continue your pain management regimen the way we've been doing it. You're off the IV stuff now. You're on the other medication. I know they gave you that long-acting medicine last night. Do you think that that helped?
Yeah, it still
It
seems
did
to
help?
work.
Okay. So we'll stick with that protocol right now, because again, a lot of times when we're concerned about chemical iatrogenic addiction, when we're concerned about that, we change the protocol, but we don't change the pain management. So we want to make sure that we limit the amount of short-acting, because short-acting works very fast, right? You notice that sometimes you get a little euphoric. Have you ever noticed any euphoria from that medicine?
I mean,
Just
I
kinda like
think
a
it's
sense
just
of
the
well-being.
pain's gone, but yeah.
Okay. And you know, again, where you're helping me help you is see where you are on the chemical coping scale. And so one of the things I want to do is get your pain level to a level of management to where you can function and do the things that you need to do so you can get out of this hospital. And then hopefully, if you come hang out with us, you can fire us within the next 6 weeks. You won't have to go from pain doc to pain doc, because I'd like to see you have a better life than that, if that's something you'd be willing to try.
Okay.
Okay?
Sure.
Cool, man. Well, you're not as tough as I thought you were. The doc said you were tough. Yeah. So most of it's just kind of being scared, isn't it?
Yeah, I guess a little bit.
Yeah. Well, the good news is that you're going to meet a lot of other people that were scared too, and they'll help you even better than I can.
Okay.
Okay, bud. Good to see you.
Thanks.
All right. My philosophy for the business of pain management addiction is probably a poor philosophy. I really don't want continued business. I want people to get through here, get in here, and get out of here and go enjoy their lives. We see too much medicalization of things that really ought not to be medicalized. We're not good at giving time. We're very demanding in and seeking curative treatments. And with regard to the way we manage pain in a chronic basis, that's a different world. And it's interesting, in the acute care of the chronic pain patient, we can go that same route in maximizing that patient's pain management while minimizing their relapse, using long-acting opioids, avoiding short-acting IV, short-acting PO, using something that's going to help that patient manage their pain, using other types of things besides opioids. Opioids are the hallmark for acute pain management. We all understand that, but there are other ways to manage that pain. And also, when we're dealing with a recovering person, helping that recovering person continue their recovery program and honor that recovery program, but also prevent needless suffering by providing management, education, and pain management as well in the form of opioids, even if there was an opioid addiction present. Benjamin Franklin said, "The most fatal thing to health is an overcare of it." And we live in a country, in a society, in a time to where we can diagnose anything with an x-ray. You can see a bulging disc and create a patient instead of a person that has a bulging disc. So one of the things we have to do as clinicians is help normalize the cycle of pain. The treatment of chronic pain and chemical dependency is not unlike the treatment for any other chronic illness. Each level of what I call a platform of care, the patient has the denial and resistance to treatment. Then perhaps there's some treatment and some lifestyle change, but maybe some relapse back into old behaviors. Maybe they're laying on the couch too long and they're not exercising, or they're not following their holistic program. So continuing to get that patient into a level of health care and a style of living that maximizes that function and minimizes the symptoms of pain from the chronic non-cancer pain standpoint is something that happens over time. The pain disease and the addictive disease didn't get immediately bad, and the recovery from such is not going to be equally fast. So one of the things that we have to understand is that we have to meet that patient where they are. And then once we get to that point, then we can do something to help that patient and get on the other side of that particular crisis or that particular part of their lifestyle that's not conducive to recovery. Alex, I'm Jim Reiser.
Hi.
And I run the chronic pain program here, and Dr. Jones had referred you to me, so I wanted to tell you a little bit about the pain program. Before we get started with that, though, can you tell me about the pain that brought you here?
Yeah, I just have lower back pain all the time. It's
Okay.
constantly just firing.
Okay, so you're pretty miserable, huh?
Yes.
What have you used for the pain?
Everything. I've been prescribed fentanyl patches, Oxycontin, and they just stopped working, so I just kind of stopped taking them.
Okay. Did you find yourself functioning poorly, or were you feeling badly on the medications? What kind of things were going on? Did you stop them, or did your physician stop them?
The Oxycontin I kind of stopped, and then I went through, like a detox. But they kind of just made me really sleepy, and then it was hard to take care of my two younger kids.
Okay. Did they treat you for chemical dependency? Did they think that you had an addiction to these meds, or were you
No.
just... Okay, so you didn't really have any addiction issues.
Mhm.
Okay. Well, let me tell you a little bit about what we're going to do here with our program. I know they told you a little bit about it, and unfortunately, the bad news is also sort of the good news. With regard to all of the things that they've looked at medically with your history, there's really nothing that science supports to help you more with a procedure or surgery or anything like that at this point in time. That doesn't mean that we're going to give up on that. That just means, what are we going to do to maximize what you've got? Okay, you've had some pathology in your back. You're telling me that you're not able to take care of your family the way you'd like to, and I want to try to maximize your function as much as you can. And unfortunately, in a program like this, we kind of have to learn to live within the limits of the body and kind of let life fit into your body, if you will. A lot of times we've added medications trying to do more than we should and end up injuring ourselves, and that's something that I don't want for you. So what our program consists of, it's a 12-step based program. So we work with the same principles that started AA, and the reason that we do that is because that's a chronic illness type of a treatment. And a lot of times people with chronic illness don't want to have chronic illness. You and I both want, if we get something wrong, we want it to be fixed. Mm-hmm. And in situations where things can't get fixed, then we have to say, okay, what do we do? How do we change? Sometimes it's lifestyle, sometimes it's the way we do things. There's all kinds of different things that we can do to minimize your pain, but I won't lie to you and tell you that you'll be pain-free. How does that sound to you?
Well, I don't think I have an addiction problem.
Okay.
Because I've been prescribed and I see a doctor regularly, and but I could look into it definitely.
Okay. How does the prospect of having some pain, in spite of the fact that you'd rather not have it, sound?
It makes me a little nervous.
Yeah, a little bit nervous, okay.
Yeah.
What have you been doing for your diet and your exercise?
Well, I just had a baby 8 weeks ago, so I'm just now starting to exercise again.
Great.
But, you know, I haven't, and I don't eat very well, so that
Okay.
probably adds to my pain.
Well, the good news is that's part of what we're going to be doing. Is we're looking at you as a whole human being. We're looking at your body, we're looking at your mind, and we're looking at your spirit, and we're looking at all of these things. And that's the part of the program that's really nice, is because you're going to be able to meet other people just like you that have chronic non-cancer pain that's likely not going to go away, that they've tried different procedures, different surgeries, different medications, and some people do have an addiction to these things. And how I see it is that if that presents, like say that you start relating to some of the folks that have had some addiction issues and you're afraid of that, I don't care about that. I don't care if you have addiction or don't have addiction, because the treatment protocol is the same. My job is to help you have a better life, have a better lifestyle, and then to fire me within the next 6 weeks. Is that something you'd be interested in doing?
Yeah.
Cool, I like it. All right, well, what we'll do is I'll get you set up with the Access Center, and we can get you seen within the next 24 to 48 hours, and we'll go from there, okay?
Okay, awesome.
All right, good to see you, man.
Thank you.
All right, look forward to working with you.
You too.
Okay. Thanks for watching these vignettes today. These are dynamic, and we want people to respond and say what worked for them and what didn't work for them and what is working in a situation where we're dealing with a difficult to manage pain on a patient with and without chemical dependency. One of the things that we remain hopeful for here is to put the focus not on the pain, but the focus on the function. Because people need to understand they're going to have some discomfort. They need to understand they may have a lot of discomfort. But the journey as specialist, team, nurse, physician, patient, and family is to minimize that disruption from the pain as much as possible, especially from the acute side. But when people's expectations are a little too high, that's where I believe we get into the most trouble. So when we're telling patients, listen, this is going to hurt, you're going to have some pain, you're going to have some recovery time, you're going to have to take some time with this, patients have a better outcome because they've been told, in my opinion, more truth about what they're going to be dealing with. We've definitely hit a side of the pendulum of addiction that I hope that as that pendulum begins to swing back from the continued addiction, that we don't go too far the other way and refuse any kind of pain medications. There are times when pain medications are appropriate and necessary. And as time goes by, we will continue this art and this practice of medicine as we help our patients have better, more productive lives and have pain be a less disruptor.